Hi, this is Shyam Varadrajulu from Orlando, Florida, and I'm going to talk to you about endoscopic management of pancreatic fluid collections, and thanks for the opportunity to speak to you today. As of 2022, present evidence clearly says that endoscopy is preferable to surgical and radiological approaches for management of pancreatic fluid collections with a treatment success that exceeds 90%. Reinterventions, length of stay, rehospitalization, and costs are significantly higher when treating necrotic collections compared to pseudocysts, and lumen-opposing metal stents are preferable to plastic stents for management of any pancreatic fluid collection. If we have to make an advance in the way we treat our patients, I think we need to know how to manage necrotic fluid collections better. Therefore, my talk will focus primarily on management of necrotic fluid collections. Improving outcomes in necrotizing pancreatitis is threefold. One, when the patient is in the hospital, we need to treat them in a way that we decrease reinterventions. Once we do that, we need to get the patients out of the hospital. The average length of stay for patients with necrotizing pancreatitis is about 18 days, and there are several things that we can do to expedite discharge. Because one, a patient out of the hospital is a more healthy patient, and two, it significantly decreases hospital costs. And finally, after discharge, we need to make sure that the patient will not have to come back and get admitted with a recurrence. And for that to happen, we need to treat the underlying pancreatic duct disorder. So now let's focus on the first part, how to decrease reinterventions. It all depends on the type of stent that we place. There are two kinds of stents for the most part, a 15 mm and a 20 mm stent for managing necrotic collections. The 15 mm stent can be used for treating patients when the fluid collection is further away from the gut wall, because usually the stents are only 10 mm in width, and the longer stent enables us to access distant collections. The 20 mm diameter stent is preferable when necrosectomy is anticipated, and once these stents are placed, a necrosectomy can be performed at an index session without much of a problem. So I'm going to show you this particular case where a patient presented with a fluid collection, and as you can see that the collection is located very further from the transducer, and this was approximately 17 millimeters. When that is done, traditional teaching is that we shouldn't access those collections, but that not necessarily is not true. Here we placed a stent that are not completely reached into the collection, and then we dilate the lumen of the stent with a longer balloon so that the proximal end of the balloon is way distal into the cavity. And once dilation is performed, we can go through the stent and access even distant collections. And usually the distance we can go is approximately 2 to 2.5 centimeters. So therefore, the distance from the transducer is not an absolute contraindication for endotherapy. Secondly, when placing stents, it's important to know where to place the stent. It's very critical to avoid the proximal part of the stomach and to place the stents at the distal portion so that the collections can be accessed with relative ease, and it is easy to perform an endoscopic necrosectomy. So in this particular case, a patient presented to us with a large necrotic fluid collection, and this fluid collection can be seen from the proximal stomach at the G junction. But also, when advancing this echo endoscope into the distal stomach, we can still see the fluid collection quite well. And I would recommend that the stent be placed through the distal most part of the stomach, because it enables an easy access to the necrotic cavity with a gastroscope should a necrosectomy be performed. Here you can see that the distal flange is being placed and then eventually deployed
This location
into the
in the
stomach.
distal
And
gastric
this is a
body
much
is the
desirable
ideal position for
location
direct
to
endoscopic
perform a
necrosectomy.
necrosectomy should
After
that be
stent
required.
placement, the wall of necrosis cavity was irrigated with normal saline. On the other hand,
On the
in
other
this
hand,
case,
in
the
this
lens
particular
has
case,
been
you can see
deployed in
that
the gastric
that
cardia,
the stent is
and the
placed
cavity
through
could
the
not be
proximal stomach,
accessed
and it is
endoscopically,
very, very
and the
difficult
patient
to
eventually
access these
required
collections
a
to perform a
percutaneous catheter
necrosectomy. Therefore,
placement
before
to augment
embarking on an
drainage.
intervention, always try to access collections from the distal stomach, then the proximal stomach. The third significant factor
First, the wall of necrosis was punctured using the tip of the
to make sure
electroporter-enhanced delivery system.
that irrigation is
distal flange
performed.
of the
So you
stent
can
was
see
then
that we are
deployed.
placing a luminopoussing metal stent in the stomach, and then afterwards we are placing
followed by
an
deployment
ERCP
of the proximal
cannula
flange,
into the
which was
collection
irrigated
in
with
order
normal
to
saline,
irrigate the stent.
using an ERCP
It is very
cannula
important
that
to
is
take
passed
another
through
5
the working
minutes
channel
after
of the
stent placement to
endoscope, which is in
irrigate,
turn
to remove as
attached to a
much
tubing
necrotic content
from
as
the water
possible, and
pump.
you can see a large amount of
Stent
solid
placement
debris
is
passing
just the
out.
first step
However,
in
in
the
this
treatment
patient, unfortunately,
algorithm. It is very
presented
important to
later
perform
in the
adequate
hospital
irrigation at
with
index
significant fever
intervention,
and chills,
done,
and when
then
we performed
residual
an
debris
endoscopic ultrasound,
resulting in persistent can be seen in this
we were
video,
able to see a lot
where
of
residual
debris
debris
clogging the inside
occluded
of
the
the
lamb's
stent, and
lumen
that
and
required
caused
more
post-intervention
irrigation to clear
sepsis.
the
This
channel of
patient
the stent.
required a
Therefore, when
repeat
the stent is placed,
intervention
always
where
spend a few
the
extra
wall of
minutes
necrosis
to
cavity
irrigate the necrotic
was
cavity
irrigated
before concluding the
aggressively.
procedure. This is a protocol that we have designed for managing pancreatic fluid collections. So in patients with pseudocyst, one can place a metal or a plastic stent, but however, if there's a chronic calcific pancreatitis with stones blocking the main pancreatic duct, I will recommend placing plastic stents and not metal stents, because these stents have to be left in situ indefinitely. In patients with necrotic collection, if there's a large collection, a single 20 mm stent will be suffice. But if the collection is being clearly separated by a thick septation, then you've got two discrete collections that will require two different stents into each pocket. Sometimes you will have a disconnected pancreatic duct syndrome where you have a viable pancreatic tail. In these patients, you can drain the pancreatic fluid collection into the stomach in the hope that the stent can be exchanged for a plastic stent at a later time to enable the distal pancreas to drain into the stomach. Alternatively, one can place both a metal and a plastic stent at the same time, leaving the plastic stent to involve and removing the metal stent in 3 weeks' time. Finally, in patients with large pancreatic fluid collections that extends into the lower pelvis and the abdomen, then you have to perform a dual modality treatment where one collection is drained from the stomach and the collection in the lower abdomen or the pelvis can be drained through an external percutaneous catheter called the dual modality treatment. This is our outcomes with management of close to 400 patients, where we used a strategy of using both metal and plastic stents versus only plastic stents, and you can find there's a significant success rate when the Orlando protocol is adapted, yielding superior clinical outcomes in these patients. It is also not uncommon to find multiple large collections are seen in these patients. How do you manage these patients? In this particular case, you will see us advancing the echo endoscope into the distal small bowel, and on echo and on sonographic view, the fluid collection can be easily identified. It is important to know that the small bowel wall is thin, and therefore, if you are draining collections through the jejunum, there is a significant risk for perforation. Therefore, every attempt should be made to drain these collections through the stomach or the proximal duodenum if required. So in this particular case, you can see that the fluid collection from the stomach is clearly visualized, and here you are finding an anechoic area with a lot of septations, and we are draining this fluid collections through the stomach by placing a lumen-opposing stent, and once that is done, clear fluid comes out, and this is probably a reactive pseudocyst. Now we are looking at the other collection on the stomach, and you can find a large amount of debris, and this is more necrotic than the prior collection. And after drainage, you can find that much more thick viscous fluid comes out of this collection, and this was clearly a necrotic collection. And after draining both these collections, when the echo endoscope is advanced into the duodenum in the same patient, you will find that the fluid collections have completely resolved, and this is why these collections communicate with one another, and it is not always readily appreciable on a CT scan or a MRI. Therefore, it's important to drain them from the stomach as much as possible, and then when you go back into the duodenum, you'll find that most of them have already collapsed because they were all communicating, and this happens in 15% of patients. When do you perform a necrosectomy? I will recommend that an index necrosectomy be performed at the first procedure, where after lumen-opposing metal stent placement, there is no drainage. And this happens when the necrosis is significant and occupies more than a third of the cavity. In other patients, a necrosectomy can be undertaken at a subsequent time only if the patient has ongoing sepsis, SIRS, or organ failure. And when you do a repeat CT scan within 2 or 3 days, the fluid collection has not decreased in size by 25% or more. In these cases, we perform necrosectomy at follow-up. I strongly recommend that in index necrosectomy because when you don't have drainage, you've converted a sterile collection into an infective collection, and therefore performing necrosectomy at the index session will make the patient feel better soon. And in other patients in whom there is good drainage at the index intervention, it's okay to wait for some while to see how the patient does and then to plan treatment accordingly. So we talked about everything, about the type of stent, the location of the stent, how to irrigate the stent, how to tailor the treatment based on Orlando protocol, and then to perform necrosectomy based on initial response after stent placement. All this will decrease reinterventions in the patient. Now let us focus on decreasing length of stay in patients. So there is a recommendation that fluid collections should be drained within a 4-week period. Obviously here the collection is immature, it cannot be drained. Here there's a thin wall and one has to be careful when performing a drainage because you can cause peritoneal soilage. So waiting a few days is alright in these patients, or if you drain them, do not place a plastic stent because the guide wire can perforate through the walls and cause leakage. A lumen-opposing metal stent may be okay, but when the collection is very walled off, which usually happens after 3 or 4 weeks, then a lumen-opposing metal or a plastic stent can be placed without any problem. In this particular patient who presented to us, this was a trauma patient, and then ERCP was performed because the trauma surgeons wanted us to bridge the leak. So you can see there's a leak happening here. So a guide wire is passed beyond the ductal disruption to the distal tail of the pancreas and a plastic stent has been placed. However, the patient still developed a fluid collection around the site of disconnection on a follow-up CT scan. So within 4 days, we re-intervened and a nice thin rim is seen around the collection, and the patient did undergo transgastric drainage of the pancreatic fluid collection via a lumen-opposing stent. So the 4-week interval is not always mandatory, and this has been shown by the Minnesota group, where sometimes you can intervene early in the patients than wait for 4 weeks with comparably good clinical outcomes. Another thing to remember is when patients present with pancreatic fluid collection, nutrition is important. What type of nutrition should we provide? During the early phases when the collection is not walled off, the patient has got acute inflammation, and if a PEG J is placed, as we did in this patient, because of extensive abdominal distension, you can get a buried bumper syndrome. Therefore, we recommend the placement of a nasojejunal feeding tube during the initial phases. And once a nice wall is formed around the fluid collection, a PEG J is appropriate. This is a study that we presented recently comparing endoscopic drainage with a percutaneous drainage. And as can be seen, when percutaneous drainage is placed, the mortality rate at 6-month follow-up is higher. All-cause hospitalization is higher. This leads to increased length of stay and direct costs. So that the moral of the story is, if there is a fluid collection amenable for drainage by both endoscopic and radiological means, always choose the endoscopic approach if the expertise is available. However, if the fluid collection is extending into the lower abdomen and pelvis, then percutaneous drainage is important. When recommending percutaneous drainage, always make it clear to the interventional radiologist that a 16 French drain should be placed, and within 3 days it should be upsized to 24 French, because only if you place 24 French, solid debris can be irrigated and evacuated. Also, when there is more than 35% necrosis, one should anticipate the need for retroperitoneal debridement or a sinus tract necrosectomy. In these circumstances, once again, a large bore percutaneous drain is important. After placing a percutaneous drain, never wait for things to get better by itself, because they will not. And once you have a lot of solid debris, a drain will not be sufficient to evacuate them. Either the patient will require a video-assisted debridement or an endoscopic sinus tract necrosectomy. So here you can see us removing a 24 French drain, passing a guide wire, and over the guide wire we advance savory dilators to dilate the cavity. Once that is done, adult cap-footed gastroscope can be advanced via the skin into the sinus tract, and the necrotic cavity can be accessed, where necrosectomy can be performed in the standard fashion. We always recommend a lot of saline to be used during irrigation, and then when completing the procedure, use hydrogen peroxide. If peroxide is used initially, then it obscures vision because of air bubbles, and this can be unsafe to the patient. Finally, when placing these stents, it's also important to make sure that they are also removed in a timely fashion, because if you don't do that, as seen in this patient, within 72 hours of placement in a patient with pseudocyst, pulsations can be seen with extensive bleeding, and this patient eventually underwent an interventional radiology guided coil placement. And here you can see coil that is being placed adjacent to the luminopposing metal stent, so that the cavity can be, so that the vessel can be sealed off, and on follow-up endoscopy, no vessels are seen. So therefore, it's our recommendation that these patients should be followed very closely, and if there are, and the stents removed in a timely manner. When do you follow up on these patients? In our protocol, we follow them every 72 hours. We assess them clinically and radiologically. If there's a resolution of SIRS and sepsis, and if the fluid collection has decreased by greater than 25%, we call it clinical response. If there is no clinical response, then if there is liquid debris, additional stents are required, and if there is solid debris, a necrosectomy should be undertaken, and a 72-hour reassessment should be undertaken. This is our study, the Mysore trial compared to the Dutch pancreatitis study group, and you can see that despite patients being more sick, having a higher CT severity index, the number of interventions that we required was significantly less than the Dutch trial, with the length of stay being only 16 days compared to 53 days in their group. We have just concluded a randomized trial comparing elective step-up approach for endoscopic necrosectomy versus index necrosectomy at the very first session. The study has been concluded and we are awaiting follow-up data to know the primary outcome measure in this clinical trial. Finally, how do you decrease recurrence? It's not enough to just discharge the patient from the hospital. It's also important to make sure that they don't come back with a recurrence. There are three problems here. The duct can be disconnected, it can be obstructed, or it can be disrupted. Sometimes when you've got a disconnected pancreatic duct, such as seen here in the body of the pancreas, but the distal pancreas does not communicate with the major duodenal papilla, on follow-up, after confirming that the fluid collection has resolved, we will remove the lumen-opposing metal stent using a rat tooth forceps. And once that is done, you can see the pancreatic duct here entering into the cavity. So we know that this patient will have increased recurrence of the fluid collection over a 2 to 3 year period. So in such patients, we will pass a cannula with a guide wire. We will coil the guide wire into the cavity and then place a double pigtail plastic stent. And once this is done, we believe that the distal pancreas will drain through the transgastric tract and increase the chances of recurrence. Another treatment option will be sometimes the disconnected duct will communicate and create a fistula with the gastric wall, as can be seen here, and the patient can have severe pain. In these cases, what one can do is to puncture the gastric wall where the fistula occurs, and then one can flush large amount of saline into the gastric wall so that this can be enlarged. And once that is done, then it creates a sufficient cushion to undergo a elective transmural tract between the fistula and into the gastric wall, thereby providing a conduit of least resistance for the distal pancreas to drain directly into the stomach. Alternatively, one can also perform a pancreaticogastrostomy, which is a very, very challenging procedure. In this particular case, the patient already had a disconnected pancreatic duct syndrome, and the pancreatic duct in the tail was about 6 millimeters, and the patient was having severe pain. So therefore, we puncture the pancreatic duct using a 19 gauge needle, and then after dilating the transmural tract using a radial expansion balloon, the pancreatic duct is established a communication with the stomach through the placement of a double pigtail plastic stent, and this will decompress the duct, decrease pain, and hopefully create a conduit for the disconnected pancreas to drain. Finally, if the duct is obstructed, such as you can see in this patient who presented with chronic calcific pancreatitis, severe abdominal pain, and a fluid collection, we are performing an EUS and we are retracting the scope from the second portion of the duodenum. Here is the common bile duct, and inferior to that is the pancreatic duct. Once the pancreatic duct is gradually pulled, you can see that there's a stone that is blocking the pancreatic duct, and beyond that is a large pancreatic fluid collection, which is approximately 8 centimeters in size. Here, a lumen-opposing metal stent, if placed, will create a problem because once the stent is removed, the duct is blocked, the distal pancreas will have nowhere to drain, and the patient will develop a recurrent fluid collection. So here we are demonstrating and confirming this on a pancreatogram, and subsequently this is followed by placement of a double pigtail plastic stent via the transgastric route so that the tail can drain into the stomach even if the stone is not removed. Here is a patient who presented to us with a pancreatic duct leak, or what I call a disrupted. This is not a disconnected but a disrupted duct. A stent was placed in the bile duct, but unfortunately through the pancreas, and therefore it caused a major leak in the pancreas and the patient was sick. So we pass a guide wire here into the tail of the pancreas very, very carefully, and a stent is placed bypassing the leak in the pancreatic duct and thereby letting the pancreas to heal and minimize fluid collection recurrence. I'm going to leave you once again with this cartoon demonstrating the Orlando protocol for endoscopic management of pancreatic fluid collections. And if you have not read this paper, it's important to read the paper because it provides a complete framework on how to manage these patients. So our progress in management of pancreatic fluid collections really depends on how well we manage necrotic collections, because the debate with pseudocyst has been settled in favor of endoscopy and there's no controversies. Necrotic collections are challenging, and if the principles outlined in the lecture can be followed, these patients will have fairly good clinical outcomes. Once again, thank you for your time and the opportunity to present, and I want to thank Yogesh Shastri for inviting me for this lecture. Thank you.